The objective response rate was 73.5%, with ORR approaching nearly 90% in colorectal cancer. Among G12C inhibitor pretreated NSCLC, objective response rate was 30% with 80% disease control rate. These findings were independently reported in Cancer Discovery and Nature Medicine. So today, we present the full expansion data of phase 1-12 in second-line plus G12C mutant NSCLC patients naive and refractory to KRAS G12C inhibitors. Coming to the study design, this study consists of phase 1 dose escalation followed by phase 2 expansion. In phase 1 part, patients with locally advanced or metastatic KRAS G12C mutant solid tumors were treated across multiple dose levels to evaluate safety, tolerability, and RP2D. Notably, no DLT was observed and MTD was not reached, and 600 milligram QD was selected as RP2D. In phase 2 part, we enrolled both G12C inhibitor naive and refractory NSCLC population. For G12C inhibitor refractory population, patients were required to receive only one prior G12C inhibitor treatment and to achieve best response of a PR or CR regardless of treatment duration or stable disease for at least 6 months. This enabled a focused evaluation in clinically meaningful refractory population. So here we summarize the patient demographics. Patients were in their 60s, predominantly male, and were enrolled globally, about half from China. Majority of patients had ECOG PS1. Importantly, disease burden was substantial. About 20% of patients had brain or liver metastasis at screening, and some of diameter of target lesion were over 40 millimeters. And then about 40% of patients had at least 2 prior line of therapy, and about 60% of patients had about 40% of patients had 3 or prior line of therapy in G12C inhibitor refractory patient. So here we summarize the safety profile in G12C inhibitor naive and refractory population. Grade 3 or higher TRAE occurred in about 14 to 16% of patients. Serious TRAE were infrequent, and importantly, there was no grade 5 events. And TRAE leading to discontinuation occurred in only 1 to 3% of patients. And those modifications were infrequent and mainly driven by gastrointestinal events. So now looking at the efficacy in G12C inhibitor naive population, you can see waterfall plot in this population. Vast majority of patients showed significant tumor shrinkage, as you can see here. Confirmed objective response rate was 53.6% in all those, and 52.9%, including 1 CR, and nearly 100% disease control rate in 600 milligram QD dose. Here we summarize the duration of response and progression-free survival at RP2D. Median duration of response was 16.5 months, and median PFS was 12.2 months. With a median follow-up of 12.2 months, median OS was not matured, with 72% 12 months OS rate. Quickly switching gear to G12C inhibitor refractory population. Here you can see waterfall plot. Majority of patients showed a tumor shrinkage, as you can see here. Confirmed objective response rate was 32.3%, and disease control rate was nearly 84%. Coming to the duration of response and progression-free survival in G12C inhibitor refractory population, median duration of response was 15.6 months, and median PFS was 8.1 months. With a median follow-up of 12.2 months, median OS was not matured, with 70% 12 months OS rate. So in the case one, this is a representative case of heavily treated G12C inhibitor naive patients. This 67-year-old old male had progressed after first-line chemoimmunotherapy followed by second-line docetaxel. Upon treatment with elisrasib 600 mg QD, the patient showed achieved confirmed partial response as early as 1.9 months with rapid and marked tumor shrinkage. The tumor response was not only rapid but also durable, with the patient remaining on treatment longer than 2 years. Second case highlight potential of CNS activity of elisrasib in G12C inhibitor refractory patient. This patient had progressed on G12C inhibitor based combination therapy followed by chemoimmunotherapy. Upon treatment with elisrasib, the patient, the brain lesion showed marked shrinkage with continued improvement at the later time point. The patient remained on treatment for nearly 10 months. So in conclusion, elisrasib monotherapy demonstrated robust and durable efficacy in G12C inhibitor naive and refractory patient population. At RP2D, objective response rate was 58.8% with 16.5 months median duration of response. Median PFS was 12.2 months with 72% 12 months OS rate. Amongst third-line plus G12C inhibitor refractory population, objective response rate was 32.3% with median duration of response of 15.6 months. Median PFS was 8.1 months with 71% 12 months OS rate. Importantly, in 5 patients with KRAS amplification, we observed objective response rate of 60% with 100% disease control rate. The safety profile of elisrasib remained favorable and consistent with phase 1 dose escalation. ctDNA data demonstrated deep and rapid molecular response and without emergence of KRAS amplification, which correlate to differentiated target engagement mechanism of elisrasib. Based on this promising efficacy and safety profile, elisrasib monotherapy received breakthrough therapy designation and fast track designation in NSCLC and warrants a pivotal trial of monotherapy and combination with checkpoint inhibitor in the frontline setting. Thank you for your attention.
As we move on to the questions, a reminder that if you're joining us by Zoom, please submit your question using the Q&A box. We'll begin with a question from the moderator, Dr. Desai.
Thank you, Dr. Cho. That's a great presentation and clearly impressive data. While we're waiting for others in the room, I might ask the first question. And my question is, do you elaborate further on the mechanism of action of this agent? So this is a GDP inhibitor, and yet the results do look to be quite impressive, both in G12C inhibitor naive patients as well as those who have been pre-treated. Could you elaborate further on how this particular agent differentiates itself from other G12C inhibitors, both approved and in trials?
Okay, so this elisrasib has a differentiated mechanism of action among all other G12C inhibitor. This is a GDP-bound RAS off G12C inhibitor, but it functionally mimics RAS on KRAS G12C inhibitor by having rapid and potent and complete target engagement mechanism. We demonstrated this rapid and potent target engagement in multiple preclinical model, and it demonstrated activity against RTK-driven resistant mechanism PDX model and G12C amplified xenograft model, and this translates into our clinical efficacy data in both G12C inhibitor naive and refractory population. So in summary, the key characteristic of elisrasib is rapid and potent target engagement, and speed of target engagement is important to generate potent efficacy.
Okay. And if I can elaborate further, in patients who develop resistance to prior G12C inhibitors, in those patients who didn't respond to elisrasib, do you have any insights based on the ctDNA data you have as to what those mechanisms of resistance were?
Okay, so the resistance mechanism to elisrasib in the refractory setting is so heterogeneous. As we can easily expect, those tumors harbor well-known bypass tract activation, RTK activation, KEAP1 mutation. So it's really hard to understand the single mechanism to confer resistance to elisrasib in resistant setting.
Okay. Excellent. And we have a question from the podium, from the grant.
Hi, Eric Fitzsimmons, Cancer Today magazine. Could you elaborate a bit more on the adverse events, specifically the grade 3+? What were the adverse events that you saw in this study?
So the drug is very well tolerated in our patient in this heavily pretreated population. As I've already mentioned in my presentation, majority of TRAE were gastrointestinal event, nausea, diarrhea, vomiting, predominantly grade 1. Most importantly, any grade AST, ALT elevation occur in only about 10% of patients, with majority being grade 1. And there was single episode of grade 3 AST, ALT elevation observed in same patient in G12C inhibitor naive cohort. So this is important because many G12C inhibitor is being combined with checkpoint inhibitors. So hepatotoxicity, important point to consider when you combine G12C inhibitor with a checkpoint inhibitor. So I think in addition to other toxicity safety profile, liver toxicity profile, favorable liver toxicity profile of elisrasib is noteworthy.
Great. And Dr. Desai, did you have any response to the efficacy we're seeing here and what it means to you?
Sure. No, it's a good question. So I think the efficacy clearly measures up when we look at this relative to other G12C inhibitors, noting, of course, we're comparing one agent to another across different trials. You know, I think, to my understanding, the mechanism of action of this agent with these really fast dynamics around target engagement, you know, therefore suggesting it behaves almost like an ON inhibitor or a GTP inhibitor, you know, I think that does translate into what looks like high response rates, and I think particularly impressive response rates in patients who are resistant or refractory to prior G12C inhibitors, and I think that's clearly another space there as well. I mean, I think more will follow, obviously, with further data, but you know, I think the hypothesis behind why this agent might work, as has been published, and the results that we're seeing, I think certainly stand out.
This is way too high for me. Hi, Lele with Endpoints News. Can you elaborate on why, for the refractory patients, you select patients who've already responded to previous G12C inhibitors? Is the expectations that patients who, like the 2/3 of patients who didn't respond to previous G12C inhibitors, would not respond at all to this drug? And then second question is, can you also elaborate-
so are you asking about eligibility criteria?
Yeah.
Okay, that's a good point. So as I've already mentioned during my presentation, we really want to select patients with clinically meaningful resistance in the clinic. So we selected criteria: patient were required to receive one prior G12C inhibitor and to achieve CR or PR regardless of treatment the duration of treatment, and or stable disease for at least 6 months. Meaning that this population has truly resistance to prior G12C inhibitor.
Got it. I guess, can you explain like the meaning behind clinically meaningful resistance versus like patients who did not respond at all to the G12C inhibitors?
So I think so clinically meaningful meaning that patient derived initial clinical benefit to prior G12C inhibitor, then ultimately develop resistance. That means that clinically meaningful resistance. And then patient achieved responses or stable disease for at least 6 months. That defines clinically meaningful resistance in our study.
Got it. And then would you look at patients then who didn't respond to previous?
We didn't evaluate such a population in our study because, those population may not depend on KRAS signaling pathway because they developed de novo resistance, primary resistance to a prior G12C inhibitor. Although they have G12C mutation in the tumor, those tumor G12C mutation may be subclonal, may be independent of KRAS signaling pathway, and then we believe those population may not be appropriate in our study.
Got it. And can you elaborate on the phase 3 plans for this agent?
So we are actively investigating elisrasib as a monotherapy, as well as in combination with checkpoint inhibitor in the first-line setting. And we are actively investigating this drug in colorectal cancer and pancreatic cancer.
Excellent. Thank you, Dr. Cho. Julia?
Dr. Desai, we're ready for our next speaker.
Excellent. Thank you, Dr. Cho.